Okay, so this is a recording of the live lecture for the Grade 5 Passive Mobilization given by myself, Michael Jean Favor, Taylor Douthit, and Lauren Jarmus as a part of the Stanford Healthcare Orthopedic Clinical Residency in the year 2020. The overall objectives for the pre-lecture as well as the live lecture will be for the residents and the audience to be able to define a high velocity, low amplitude thrust, or HVLAT, explain the current theory of a cavitation, understand the refractory period following a cavitation, appraise and understand the contraindications of the HVLAT, evaluate the risks for and against a high velocity, low amplitude thrust versus like a non-thrust, demonstrate safety and proficiency of the performance of the HVLAT manipulation for the upper cervical, cervicothoracic, thoracolumbar regions of the spine, and include pre-thrust positioning and application. All right, and so we're going to start off the presentation with the introduction and definition of HVLAT, and that will be presented by Taylor.
So we're going to start off with our introduction and definition of what is an HVLAT. A high velocity, low amplitude thrust is a therapeutic movement that's performed at a high speed within a relatively short distance within or at an in range of motion. And these techniques are designed to restore joint motion, particularly in joints that have a restricted range of motion. So remember, HVLAT is known through the US and throughout the world as different things. In California and certainly in the rest of the US, it'll depend on the practice act of our boards. And so a HVLAT is synonymous with a grade 5 mobilization, which can also be synonymous for a manipulation. However, in California, we use the term HVLAT or grade 5 mobilization. In 1998, the APTA Guide to Physical Therapist Practice commented saying that this is a skilled passive movement to joint and or related soft tissues at varying speeds and amplitudes, including HVLATs. And then it was updated in 2014 saying that it was a skilled hands-on movement and skilled passive movements of joints and soft tissues intended to improve things like range of motion, joint relaxation, help modulate pain. And in those manual techniques included things such as traction, massage, and then mobilization and manipulation. So we don't call these adjustments. We utilize these in the treatment of neuromusculoskeletal pain and dysfunction in order to restore mobility within those systems in particular. And we don't utilize it to manage or co-manage or even prevent diseases or conditions in the body systems such as the immune system. Stated by a gentleman named Joe Waller. And so essentially, when we perform a high velocity, low amplitude thrust, we're looking to restore mobility through neurophysiologic or musculoskeletal mechanical mechanisms.
All right, and so we're going to start off the presentation with the introduction and definition of HVLAT, and that will be presented by Taylor.
So here's the clinical application. And here are the indications for why we might apply a high velocity, low amplitude thrust. Some of it can include joint restrictions, so hypomobilities, joint fixations, acute joint locking, adhesions. Might be looking to restore bony alignment, or if we have a meniscoid entrapment, or if there's a displaced disc fragment. We have motion loss with somatic dysfunction or just pure somatic dysfunction. Also looking to modulate pain, release endorphins, relax muscles, and even thinking about reprogramming the central nervous system. Again, we have our clinical prediction rules to help guide us as well. And so that takes us into the OCS testing, where we see that the clinical prediction rules pop up. And so for cervical manipulation for neck pain, we have Puentadora in 2012 looking at when is it appropriate to manipulate when we have neck pain. And they suggested that if you have symptoms less than 38 days, if you have a positive expectation that the manipulation will work, if there's a side-to-side difference in cervical rotation of 10 degrees or greater, if there's pain with PA spring testing of the middle cervical spine, then 3 out of the 4 variables presents with a 90% probability of success, and all 4 of the variables, if a patient has it, puts us at a 100% probability of success. Another article that looked at cervical manipulation for neck pain and when was appropriate was suggested by Sang et al. In 2006. And if there was an NDI of less than 11.5, if they had bilateral involvement, they didn't perform sedentary work for more than 5 hours per day, if they were feeling better while moving their neck, they didn't feel worse with going into extension, and if they had a diagnosis of spondylosis without radiculopathy, we see that having 3 out of 6 variables put them at a 74% probability of success. If they had 4, it bumped them up to 89. If they had 5, put them all the way up to 100. Cervicothoracic manipulation for shoulder pain, as suggested by Mintkin et al. In 2010, suggested that if there was pain-free shoulder flexion below 127, there was shoulder internal rotation less than 53 degrees at 90 degrees abduction, they had a negative near test, and if they were not taking medication for their shoulder pain and had symptoms less than 90 days, put them with 3 out of the 5 variables having an 89% chance of success, and if they had 4 out of the 5 variables, then they had 100% probability of success. Here's a big one for manipulation for low back pain, given by Flynn et al. In 2002, which you might remember from your treatment-based classification systems. Having duration of symptoms less than 16 days, having at least one hip with 35 degrees or more of internal rotation, if they had a hypomobile lumbar segment, no symptoms distal to the knee, and if they had a FABQ work score of less than 19, 4 out of the 5 variables put them at a 95% probability of success, and if they had all 5, it knocked them all the way up to 100. Here's Cleveland et al. Looking for thoracic manipulation for neck pain, and no symptoms less than 30 days, no symptoms distal to the shoulder. If looking up does not aggravate their symptoms, they have a FABQ-PA score less than 12, diminished upper thoracic spine kyphosis, and cervical extension range of motion less than 30 degrees. Having 4 out of the 6 put them at a 93% probability of success, and having 5 out of the 6 put them at 100. And here's our poll that we will be asking to our residents and our other attendees for when it is appropriate to perform the intervention.
Okay, thank you all so much for listening. Please feel free to leave your comments, questions, concerns, and feedback in the sections below, or contact one of us, that is to say myself, Taylor, or Lauren directly. We'd be happy to answer and provide further detail when and where appropriate.